I would like to introduce Prof. Laurie again. She's going to talk to us about robotic surgery in head and neck cancer, what the radiologist needs to know about the cutting edge. Thank you.
Well, while this is opening, I want to re-emphasize there's nothing more important, nothing, than working with your clinical colleagues. That's what makes you an expert. So I spend most of my day with oncologists and heme-oncologists and radiation oncologists and surgeons. So that's what makes you the consultant. So I would highly suggest that. What I'm going to do in the next 20 to 25 minutes is talk to you about robotic surgery in the head and neck. How many people have heard of it? We've got, okay, good. How many people have it at their institution? Okay, well, it's coming your way. So I think this is really important to discuss today. So first, I'm going to introduce the robotic technology to you. We're going to discuss applications and advantages of robotic surgery, so trans-oral robotic surgery. We're going to discuss the role of imaging in determining candidacy for TORS, trans-oral robotic surgery. We'll look at a few normal post-operative appearances, and we'll illustrate a few patterns of recurrent disease. So we all know together as clinicians that the goals in treating head and neck cancer are first and foremost to cure it, but also to do so by providing good quality of life, to maintain or at least improve the social and functional outcomes in speech and swallowing. And so we're all very vested in having organ preservation surgeries, whether that be more minimally invasive operations, chemotherapy, or radiation. Again, we're looking for conservative therapies. Now, classic open surgical procedures have a lot of morbidities. In addition to the marked cosmetic deformities, functional losses, including speech and swallowing, are quite high. Open surgery that is often followed by radiation for mop-up carries up to a 30% risk of patients requiring long-term gastrostomy tubes, tracheostomies, and/or lifelong mucositis. So organ and function preserving therapies, so some surgical conservative therapies. We've moved on to selective neck dissections, partial laryngectomies instead of full laryngectomies, minimally invasive surgeries such as transoral laser microsurgery, and of course, radiation and chemotherapy. 2 decades ago, when I was coming out of fellowship, there was a marked trend towards primary, upfront, definitive chemoradiation for oropharyngeal cancer. Of course, the advantages are organ preservation and reduced distant metastases. Most of these, again, had chemotherapy. Potential issues, of course, are functional outcomes, long-term feeding tubes, and local control. So remember, when you do surgery, you normally know if you have surgically clean margins, but when you radiate, you never really know about local control. And also, this portends sometimes changes in overall survivals, particularly with HPV negative. We really want to try to treat those with surgery. So fast forward over the last 15 to 20 years, it became clearly evident that oropharyngeal carcinoma was a virally mediated tumor, HPV associated, and currently today at my institution, 80% of all oropharyngeal cancers are HPV positive. They're HPV associated tumors. These tumors occur in much younger patients and much healthier patients compared to the prior smoking population. They have much longer life expectancies, and so morbidity for a young person is not nearly tolerated as well. And for them, primary upfront chemoradiation may be less acceptable. So there were definitely needs to look for less invasive surgeries. There was transoral laser microsurgery, but that has a limited operative view. It's technically difficult, but most importantly, it's a steep learning curve, so it's not translatable. If you can't teach a procedure to thousands of physicians, then the procedure really is meaningless. It's not useful. So let's look. This is when we started developing robotic surgery in head and neck cancer at the University of Pennsylvania, where it was founded. So this is what your classic open surgical procedure looks like: cutting open the neck, splitting the tongue, splitting the mandible, trach. You can see the exposed carotid sheath here. And the goal was to try to get rid of these open procedures and find a procedure that reduced morbidity of the classic open procedures, and also to reduce either the need need for chemoradiation or if you're going to have chemoradiation to get a de-intensified dose, to improve the functional outcomes, and to have a surgical procedure that was less invasive but similar or even perhaps better than the oncologic outcomes of chemoradiation. So the robotic surgery is the Da Vinci system. It's a minimally invasive system. The surgery is done through the mouth rather than through an open approach. It's very high resolution. It provides 3D visualization of the pharynx and the larynx. And very importantly, it's got more accurate depth perception compared to the transoral laser surgery. So I'm going to show you what the robot looks like. I'm going to show you the surgeon's console, and we're going to look at the manipulator unit. That's the technical word for what we call the robot. The robot that we use has 3 arms. You can have 6 arms if you want, but for head and neck cancer, there's 3 arms, 3 robotic arms. The central arm is an endoscope that's integrated to cameras that go inside and outside the room, and the 2 laterally placed arms are the instrument arms that are performing surgery, and at the end of them, there's these small endowrists that spin 360 degrees. So these honestly were my work husbands for a decade because I spent more time with them sometimes than I did at home while this procedure was being developed. These are the 2 surgeons that developed the procedure, and I saw every single patient in the trial. This is the central arm where the camera is. This here is a lateral arm. Here's your other lateral arm. And at the end of these arms are these tiny endowrists, and this is what's performing the surgery in your mouth. So those surgeries, the robotic advantages, you get precise handling of tissues, agile instrument motion with these tiny little arms that rotate around, a direct line of sight. You're able to do endoscopic suturing, and very importantly, you tremor. It allows hand tremor filtration, motion scaling, and it really brings the hands of the surgeon through the tight opening called your mouth to the tumor, resecting it as if you had the whole mouth already open by translating the large motions of the hands to the small movements of these tiny instruments that are in the mouth at the end of the arms. So this allows improved definition and safe surgical margins, allowing en bloc resection, which is really important. You want to try to take a tumor out in one piece, and it also allows you to adapt the surgical procedure when you're looking at intraoperative findings, which is really different than a lot of the prior open procedures. So this is what the robotic surgery looks like. This is your patient. The mouth has these very fancy clamps that hold the mouth in the open position. We're constantly renovating them and updating them to find a more useful and a more agile, retractors to hold the mouth open. This is the central arm that's got the camera. These are your surgical arms here. This is what the OR looks like. So this is really different. You have your patient, you've got the robot, you've got a nurse and an assistant. No other surgeons in the room, and the assistant is normally a resident. You've got the anesthesiologist most often at the foot of the bed, not the head of the bed. And then you have an electrocautery unit. You've got an instrument cart. This is where your gags are to hold the mouth. And here is your surgeon sitting outside of the operating room. So they're not in the operating room anymore. They are not in surgical scrub. And this is what the tray looks like. So this is the instrument tray. When I was going through medical school, there were tons of trays with towel clips and suture, just tons of metal everywhere. This is all the instruments besides the robot that are needed. These are the robotic arms with the endowrists. There's some little sponges and some suction for the mouth. So it's really a very minimally tool procedure. You need few tools. This is what it looks like in the OR. I did tell to the resident I thought it might be good if he was scrubbed, but nonetheless, this is the robot. You can see that it's sterile. It's in the mouth. This is the nurse, and this again is our instrument cart. Very, very simple. And this is the surgeon that really is sitting at a console, often outside of the OR suite. And how many of you play video games? So my surgeons play video games all the time because the instruments that they're working are just like playing Xbox or PlayStation or whatever those things are that you're doing. We've got cameras everywhere, and this is what it looks like. Their heads are bent in. This is what they're seeing through the endoscope, and this is them playing Xbox, basically, to control the endoris. So really, it's you can applaud. The wives can't argue about the Xbox being played at home and all the video games. Finally, at the end of December in 2009, it was a really big deal, but the FDA approved robotic surgery at Penn, and there was a big hospital celebration. I will tell you, we were doing 3 cases a week. We do 50 cases a week now. Robotically, we really don't do any more open surgical procedures for the oropharynx at all. These are some areas that TORS is applied. So T1 and T2 oropharyngeal cancers of the tonsil and the base of the tongue. T1 and T2 laryngeal and piriform sinus tumors. So typically supraglottis and piriform sinus can be done robotically. Skull-based tumors in the prestyloid parapharyngeal space, as long as they're separate from the deep lobe of the parotid gland and not going into the stylomandibular tunnel. And retropharyngeal nodal metastases, especially like thyroid cancer, just plucking them out. It's like a 15-minute procedure. And now we've moved on to non-neoplastic disease, and we're doing a lot of robotic tonsillectomies for sleep apnea. So let's talk a little bit about imaging and clinical evaluation for robotic surgery, because candidacy is important. Today, we have time for me to cover a little bit about the oropharynx, but TNM staging by the AJCC impacts the treatment decisions and incorporates the clinical exam, the endoscopic exam, cross-sectional imaging findings, all those spaces we talked about the other day that are submucosal, that are blind spots for our clinicians when they use the endoscope and their fingers. And very importantly, histology is important in our decision making. Our HPV negatives, we want to try to operate on all of them. They do better with surgery. HPV does well with surgery, or you can do definitive chemoradiation, and really the decisions there are more related to life decisions about quality of life. I also want to say that before you even look at the candidacy of the primary tumor, it's important to look at the nodes in your neck. If you have a non-resectable metastatic node in your neck, then you are not a surgical candidate for your primary tumor. We're not going to take out the primary when the neck is unresectable or vice versa. So first and foremost, make sure the neck is, if the nodal disease in the neck is operable, work with your surgeons to determine that. The 2 things that are definite, shut down, non-operable, again, are prevertebral muscle invasion or fixation, involvement of the paraspinal muscles, that's a closed down surgery, and encasement of the common or internal carotid artery. So here's an example of a large nodal mass encasing the common carotid artery, non-surgical candidate. Here's another high cervical nodal mass, we saw this earlier, invading the prevertebral muscle, here's your paraspinal muscle, and completely encasing in the internal carotid artery. Doesn't matter what the primary looked like. It could be the size of a pea. It's not going to have surgery because the neck is inoperable. So contraindications for robotic surgery in primary tonsillar tumors. So a retropharyngeal internal carotid artery on the same side of the tumor is a relative contraindication. They have to cut the constrictor muscles, and until they cut those muscles, they don't see what's behind it. You definitely don't want to hit big red when you're taking out cutting the constrictor muscles. Obviously, fixation. So this is determined intraoperatively. If it's negative, we tell them. If it's indeterminate, we tell them. And if it's absolutely present, that patient doesn't go on to endoscopy. But anything that's indeterminate, we give the patient the benefit of the doubt and let them determine that. So that's an intraoperative decision. If it goes up to the nasopharynx, if it involves bone or the pterygoid muscles, you're inoperable. Okay, and again, inoperable nodal metastases. So here's a right oropharyngeal cancer. This is a nodal metastasis, normal fat in the precervical fascia. Here's obliteration of the precervical fascia, compression of the muscles, and this was fixed in the Penn endoscopy suite, so this was not surgically taken out. Here are those constrictor muscles, this black thing here, you've got your mucosa. This is what we mean by retropharyngeal internal carotid arteries. You need to include that in your report to make sure that there's not a problem in the operating room. That's one of the most common questions I get at tumor board. This is a T1 tonsil tumor. And this is what it looks like following surgery. So you're going to get retraction of the tissues if it's a small tumor. You may see some signal abnormality in the surgical bed if you image before 8 weeks. This was a 4-week imaging, so you don't want to mistake that for neoplasm. This is a T2 tonsil cancer, and you'll see the mass here. So you're looking, there's no muscle involvement. There's a nice fat plane between that and the muscle. The mandible looks good. Very importantly, your carotid artery is not medial. It's sitting where it's supposed to be. And here you'll have your carotid artery again, nice and lateral, so not a problem for the surgeon. They really want to see a good fat plane or fascial plane between the tumor and the vessel. And just like that, they want to see the precervical fat, the fascia the fat sitting in front of the precervical fascia, just as you see here. And this patient did great in the operating room. This is what this patient looks like 8 weeks following radical tonsillectomy by robot, and 7 weeks following left neck dissection. So we do not typically do the neck dissection and the robotic surgery on the same day because we don't want to create an oral cervical fistula. So we now do the neck dissections a week before the robotic surgery. But you'll see what happens 8 weeks following surgery. You'll start to see, they took out that left tonsillar tumor. You're going to start to see retraction of the tissues to the side that now is volume deficient, and you'll see the uvula deviated to the left. And 6 months later in this patient following TORS and left neck dissection, you'll again see the resolution of the soft tissue changes, and you'll continue to see the retraction of the tissues. Here's the palate and the uvula again being pushed over towards the side of surgery, completely normal experience. Base of tongue squamous cell cancer, contraindications for TOR. Remember, inoperable neck, inoperable primary. Tumors crossing the midline endophytically, those growing into the lumen, are what we want to think about. Remember, you have to preserve a hypoglossal nerve and a lingual artery and nerve in order to preserve speech, swallowing, and to prevent aspiration. So that's why it can't cross the midline endophytically. Extension into the extrinsic muscles of the tongue, extension into the genioglossus muscle, and then very large tumors that are down low at the glossotonsillar sulcus. Frequently, they don't take out robotically because sometimes you leave an exposed carotid artery that can't be covered at the time of surgery. So some normal anatomy, right? You want to look at the mylohyoid muscle. Here's your hyoglossus muscle. You've got your midline fatty septum, your geniohyoid muscle, and you have your genioglossus. These are the papillae that separate the oral tongue from the base of the tongue. It can't involve the oral tongue. So those are the things you want to look at. Here's a nice candidate. This was a node here with some extracapsular spread. So following robotic resection, they got de-intensified radiation, 55 gray instead of 70 gray, which allows them to be re-irradiated in the future. Here is your tumor, quite exophytic, projecting into the lumen of the oropharynx, and that was very nicely resected. Now these are what the patient looks like. This was a left base of tongue tumor resected. You can see here again the same findings, retraction on the side of surgery, so retraction. There should be no solid enhancement in the vallecula or in the surgical bed, and please don't mistake the normal right base of tongue as a tumor, which is what frequently happens when the history of surgery is not provided. This is an inoperable tumor, so here you'll see the tumor. This is endophytic growth into the posterior floor of mouth, all the muscles, and extension across the midline. This is a different patient. The nodal mass is resectable. You can see the mylohyoid muscle, the hyoglossus muscle. This is the tricky part. You see how you lose the fat planes here and all the anatomy? This is all infiltrating tumor here. This is an endophytic tumor. There is no surgical candidacy here. Here's another one of these endophytic tumors also crossing the midline. You can see it in the hyoglossus. This is not a surgical candidate. And here are some recurrent carcinomas following TORS after oropharyngectomy. So these are the things you want to look for. This was a tonsillar tumor that was resected. First of all, I tell you, anywhere, whether it's a neck dissection or a primary resection, look around your surgical clips. Very, very important. Look around your surgical flaps. Okay, so clips and margins of flaps are the areas you want to look for. Here's the patient's clips after they cut the constrictor muscle, and you can see this very nasty recurrence along the posterior wall, and this was indeed fixed to the precervical fascia. So this was managed with radiation. You can also see it invading the pterygoid musculature here. This is another recurrence, and this was a low tonsillar tumor, and now the recurrence is sitting down. This is pretty bad from the glossotonsillar sulcus. It actually went into the floor of the mouth, and you can see a recurrent tumor here. And these are commonly missed, but this is the follicular recurrence in somebody that had a base of tongue resection, and you can see the mucosa here. I want you to know, looking at our large series, we do 50 a week now, a ton of this. We don't do any more. Our recurrence rate at the primary site is about 4%, which is pretty excellent. Our surgeons are also doing a lot of T3 tumors now, but they're highly experienced. We've had tons of workshops at Penn, and they've been traveling the world, and I think there's 148 countries now doing robotic surgery. So it is coming your way, and I just want to let you know the advantages of the robotic procedure. Reduce cosmetic deformity. Obviously, blood loss at surgery is minimal. Less postoperative pain, reduce risk of wound infection. Eliminate the need for a tracheostomy. Hospital stay is often 3 days instead of a week. Reduce or eliminate the need for chemoradiation. So if you take the tumor out robotically and there's poor histologic markers, perivascular invasion, lymphovascular invasion, angio invasion, or there's a positive margin, they're going to get mop-up radiation. Usually we do a de-escalated dose at 55 gray. Quicker return to speech and swallowing. They're drinking liquids, in 3 days and eating solids often by 7 days. A very short hospital stay and a short recovery time. So thank you very much for your time. I did finish in 20 minutes. I really enjoyed having you. And if you have questions, please email, because it's an exciting procedure when it's done in qualified hands. Thank you. Okay.